So today, welcome to the Family Medicine Grand Rounds for today, May 12th, 2021. Your event code for today, if you should need it for CME credit, is going to be 132047. You can register through your phone or through the CME office. If you have questions, you can also, I'll put the information here in the chat box in just a moment, but you can also use the event call-in through your phone, through their browser. But please make sure that you do register by midnight tonight in order to receive your CME credit. If you have any issues, please feel free to reach out to me, and if I'm not sure, I'll find out the answer for you. Next slide. So as we begin our presentation today, I would just remind everybody of a couple of things here. If you could please make sure that your microphone is muted once we begin. Also, if you can remain attentive to the presenter. I know that she's got a couple of polls in here today, so we'll be going through those and giving y'all some information on how to participate in that. So that will help if you could keep engaged in the session. And also towards the end, I'm going to be putting in the evaluation link. If you can help us to give her some feedback once we're all finished with the presentation. Next slide. And so this is the South Texas Regional Family Medicine Grand Rounds. We'd like to welcome everybody. And we are partnered with the South Central Area Health Education Center. And our mission statement is there. Next slide. CME transcripts are available at the CME website. You can follow the instructions there on how to obtain your transcript. But if you are having issues, please, again, feel free to reach out to me and I can help look into that, or you can reach out to the CME office. And also AAFP credit for those who are interested. You are also able to claim AAFP credit for this presentation. If you are having any issues with that, again, please reach out to either the AAFP or you can also reach out to me. And so we would like to mention that Ms. Schires has no relevant financial interest with commercial interest to disclose. And she is going to be presenting for us today an integrated model of care for patients with severe mental illness. So she is a psychology resident here with us at UT Health San Antonio. And Ms. Samantha Schires, I will let you go ahead and begin your presentation.
All right, thank you so much for the introduction. Some of my objectives today are to first provide an operational definition of the primary care behavioral health model, as well as its key components, to outline the benefits of integrated care when working with severe mental illness populations and the primary care teams treating them, as well as to highlight a couple of complex clinical issues that commonly emerge when working with patients with severe mental illness. So to get started today, just to give some background on the primary care behavioral health model, in recent years in the United States, there's been a shift in primary care service delivery through patient-centered medical home implementation. And these efforts have really set the stage for payers, primary care service professionals, and patients to really expect primary care integrated services just to be an essential component of their primary care that they receive. But nevertheless, there still remains some confusion in the literature and in the professional community regarding what some of the core goals, tenets, and strategies of this model of service delivery really is. So the first purpose and the first goal of my talk is to really provide a succinct overview of the PCBH service delivery model and to really concisely define the model, go over its core components and strategies. So one really nice acronym that highlights this model in detail and really describe some of the strategies that primary care staff might use to facilitate this model of service delivery is called the gather model. And so I'm going to go over each of these components in a little bit more detail. The first is that a behavioral health consultant using this model strives to be a generalist, meaning that they will engage with patients of any age with any sort of biopsychosocially influenced health condition. And the way that they might achieve going about this is to really accept any referral request from a primary care provider. So these might be any mental health or substance use problem of any severity or chronicity, any type of chronic disease, including diabetes or hypertension, or any type of preventative care need that the PCP is requesting help with. The behavioral health consultant also aims to be accessible to the PCP, meaning that they strive to see patients on the same day that the PCP requests help. So typically, the behavioral health consultant will engage in a warm handoff, meaning that this sort of process starts when the PCP sees a patient and identifies some type of biopsychosocial concern during the visit and requests BHC assistance. The BHC will try to respond immediately to that concern, receiving a brief history from the PCP, maybe being introduced to the patient in that moment in the exam room, or arranging to meet the patient either same day or as soon as possible. Sometimes they're able to see the patient immediately, and other times there might be a delay. The goal is always to be able to meet with the patient that same day. The behavioral health consultant takes a team-based approach, meaning that they function as a member of the primary care team rather than as an independent provider. Their goal is to maximize the effectiveness of the primary care team for the benefit of the entire clinic population, not just the patient that they themselves are seeing. And some ways that they go about achieving this are sharing the same clinic space and the same clinic resources as the rest of the primary care team. So some examples of this are seeing patients in the same exam rooms as the primary care provider, maybe sharing the same office space as the PCP or nursing staff, documenting in the same medical record, etc. The BHC will strive to be highly productive, so aiming to see a high patient volume and trying to mirror the productivity of the PCP. So they, in order to achieve this, will make use of very focused visits, using a scheduling template that makes it easier to work in patients throughout the day, and using a consultant approach to help with follow-up to make it easier to reach that high patient volume. BHCs strive to be educators, so trying to make the entire primary care team more skilled and comfortable to address behavioral health needs of their patients. And lastly, R is for routine. So a really important aspect of this model is for the behavioral health consultant to be viewed by the entire team as well as the patients as just another routine member of the primary care team. And so this starts in the very beginning through that warm handoff process with how the primary care provider first introduces the behavioral health consultant to the patient. And often that starts with introducing them as just another member of the team and as a regular part of how this type of presenting issue is treated in primary care. And so one population for whom there's been little exploration of how integrated care models really work well is for patients with severe mental illness. And so SMI here is defined as schizophrenia spectrum disorders, severe bipolar disorders, and severe major depression. And we know that for these populations that they disproportionately suffer from medical comorbidities, that their life expectancies can be reduced by up to 25 years compared to the general population. And while the PCBH model isn't growing in popularity in the United States, it's unclear how these patterns of care will change for patients with SMI once this model is adopted more regularly into practice. There is some evidence to suggest that perhaps a shift in care patterns may occur, impacting PCP panel compositions and provider workloads, but it's important to identify potential changes in these care patterns in order to better understand how to ensure efficient, high quality care for this population. Okay, so again, severe mental illness is referring to mental disorders that carry specific diagnoses, like such as schizophrenia, spectrum disorders, bipolar disorders, and major depression, that are relatively persistent, so lasting at least a year, and that result in comparatively severe impairment in major areas of functioning. So these include cognitive capabilities, disruption of normal developmental processes, and social relationships. There are other diagnoses that often co-occur in SMI populations, and these include diagnoses such as PTSD, substance use disorders, personality disorders, and OCD. The most important direct expressions of SMI and consequences of these disorders include psychological symptoms. So these are things like hallucinations and delusions. These are the most familiar features. But there are also other psychological expressions, including neurological impairment, emotional dysregulation, and reduced social competence that exert at least as much impact on personal and social functioning and produce at least as much distress as the psychotic features. By definition, SMI involves impairment in psychological functioning of such severity that individuals' ability to perform routine demands of daily life is significantly compromised. And some psychological problems are unique to SMI, but others occur in other contexts as well. But we know that when they co-occur with SMI, they often acquire distinctive qualities. So for example, depression co-occurring with psychosis can be quite different from depression in an individual with no other co-occurring psychological disorders. We also know that SMI is a social problem because of its consequences for a person's social functioning, which tend to be quite severe and pervasive. Individuals with SMI are often unable to establish or maintain interpersonal relationships and can quite often lack social support systems around them. And talking about the biological basis of SMI, cognitive impairment is one of the major features of the disorder. And the dysregulation of psychological processes is often exacerbated by neurological deficits, resulting in poor tolerance for stress, poor emotion regulation, impulsivity, agitation, social withdrawal, etc. So talking about the impact of SMI on physical health, patients with severe mental illness, again, account for a significant burden of morbidity in the population and often associated with early mortality as well. Medical illness contributes a large degree to this morbidity and mortality in the population. And what we know is that these individuals tend to have more medical illness, receive poorer care than those in the general population. We also know that they're at risk for not obtaining quality primary care services, have more difficulty taking their medications, keeping their medical appointments, and even recognizing their own medical symptoms at all. And those with SMI experience a high burden of conditions, including cardiovascular disease, obesity, hyperlipidemia, hypertension, and diabetes. Again, they're more likely to die earlier, experience more illness, receive poorer care. 50 to 90% have at least one chronic condition, with cardiovascular disease presenting the highest risk, actually accounting for over half of deaths due to medical illness. And there are various reasons contributing to poorer health outcomes for individuals with SMI, including patient level factors, provider level factors, and system level factors. So I actually am going to go to a poll, and I want you all to think of what some of these factors might be contributing to poor health outcomes for this population. So if I can get this activity to work, let's see. Okay, so this poll should be active. So if you can see the links at the top here, you should either be able to go to this link or text this number here and type a response. And I want you to think of some factors that might contribute to poor health outcomes among individuals with SMI.
I've also added the link to the website there. That is the link to the polling app that we're using. You can use that if that helps. I'm also going to put, or you can see it actually there on her screen as well, her username that you would need to use, or you can do it by text as mentioned up there at the top of the PowerPoint. So you would want to first, if you use the link in the chat, you would want to first click on that link, and then you can enter the username that I also just put there in the chat.
Okay, there we go. I'll give them a few minutes to come in. I'm not sure how well this works if you try to type more than one word, but I'm trying to piece together what some of y'all might mean with some of these responses. Okay, yeah, so I see a lot of you entered words like poor. I'm not sure if you mean like financially, maybe poor access. History. Yeah, I see poverty, isolation, healthcare system, navigating, distrust. So these are all really great responses and a lot that I'm going to touch on. So These all have to do with the various patient, provider, and system level factors that I'm going to mention. So those were all really great. First, just talking about some of the patient level factors. First, just thinking about some psychological factors like fear, mistrust, disorganized thinking, cognitive impairment, even impaired insight into illness and lack of motivation can make it really difficult for a patient to describe or recognize physical symptoms and be able to communicate these to their providers. Patients with SMI also tend to engage in less healthy behaviors and tend to be less physically active and have less healthy dietary habits. They also tend to use higher levels of substances than those without SMI. There are also certain attributes of providers that may interfere with delivery of optimal health care. So certain beliefs such as finding patients with SMI to maybe be more difficult to work with or more time consuming can lead to just a feeling of general uneasiness with these patients. So that's not uncommon. And this can just stem from providers' limited experience with this population. There's also a phenomenon known as diagnostic overshadowing, where providers may attribute a patient's physical symptoms to their mental illness rather than their medical illness, which can have the potential to interfere with the provision of medical care. And then there are various elements of current healthcare systems that can lead to abundant challenges, such as hindered access to the system, a lack of system integration that can lead to patients with SMI having a lot of difficulty just navigating the system. There's also many barriers with these patients being uninsured or underinsured, which can lead to these patients finding themselves without care at all. One common scenario that we find ourselves in often at the Center for Healthcare Services is often not being able to reach our patients for scheduled appointments. And so we often find ourselves asking the question, what does this mean and how do we respond? Do we take the kind of standard approach of reaching out to them twice for their scheduled appointment, marking this as a no-show and assuming that the patient wasn't interested in services with us? I think we have to be really careful in the assumptions that we make, taking all of those factors that we just discussed into consideration. We've been in the situation where we couldn't reach our patient only to find out later that maybe they didn't have access to a phone that week. Maybe their phone had to be turned off. Maybe they were hospitalized for a mental health crisis, only to find out that they were still highly interested in our service. So we often find that the responsibility is on us as BHCs to continue to reach out and to help guide the patient through our system and to help offer that additional support and to not make the assumption that because we're not able to reach someone that it means that they're not interested or not motivated. So next, I'm going to talk about some of the benefits of integrated care, specifically with SMI populations. What we know about the benefits of the PCBH model in general from what's out there so far, we know that much more work still needs to be done, but there is some emerging evidence to suggest that the model is associated with patient satisfaction, meaning that studies have linked the model to positive outcomes, including increased utilization and attendance of services, as well as intent to comply with recommendations, improvement in symptomology. So this is the change in patient symptoms across time. There has been evidence of improvement in anxiety and depressive symptoms, PTSD symptoms, as well as sleep and tobacco use, as well as improvement in functioning. So this includes things like everyday functioning with school, work, interpersonal relationships, and quality of life. There's also been some emerging evidence of successful implementation outcomes, including acceptability. So this is the extent of stakeholders' reports of whether the model is agreeable, palatable, and satisfactory based on their experience. Adoption, meaning PCP's intent to engage with the services as prescribed, and penetration, so the extent to which the model is reaching the people that it is intended to reach. And then talking about the benefits of the model with SMI populations specifically, there was a study that looked at integrated care and with SMI populations and found that it was associated with increased initial visits and then later stabilization for SMI populations. And so this could indicate that patients were more willing to engage in care with an integrated model in place. It could also mean that providers were more willing to work with this population with the assistance of a BHC team. Integrated services could also provide the opportunity to increase provider knowledge of appropriate treatment for this population. It could mean a shared responsibility between PCPs and BHCs for more specialized behavioral health services. And BHCs could really help providers manage the workload, teach behavioral change skills, and improve patient outcomes. So just to speak a little bit more about the specific role that a behavioral health consultant could have in a primary care setting. Again, the mission of the model is to help the primary care team manage any biopsychosocially influenced health problem with the goal of improving services for that entire clinic population. The BHC, again, is co-located in the practice and viewed as a core member of the medical team, and their services are considered a routine part of care. And their role is to really act as a consultant to the PCP. The PCP is the primary consumer. The primary outcome of the BHC's work is to enhance the PCP's ability to assist their patient. And interventions are typically brief, just due to that time-limited nature of primary care, and the number of visits tends to be typically low. The structure of a behavioral health visit is guided by this 5 A's model in our practice. And so these 5 A's are for assess, advise, agree, assist, and arrange. And these have been applied to clinical trials and brief primary care interventions covering numerous behaviors. This model is considered to be flexible, patient-centered, and applicable to a wide range of patients and presenting concerns. So in the assess phase, the BHC would work with the patient to gather information regarding behavioral health risks, physical symptoms, cognitions, relevant environmental factors. And the goal here is for the BHC to understand what factors might be impacting their health and functioning, and identify where the patient might be willing or able to really change in order to decrease symptoms, or more importantly, improve functioning. In the advise phase, this is where the BHC would inform the patient of the intervention options based on the earlier assessment. And patients are given specific, personalized, and clear advice about their health risks and benefits of change. And the goal here is for the BHC to describe the proposed intervention and expected outcomes, the options. In the agree phase, the BHC and the patient collaboratively will agree on a treatment goal and action plan. And the goals and plan may be based on the BHC's recommendations or created by the patient. Whichever is selected, it's again based on the patient's willingness to make a change. In the assist phase, this involves the actual delivery of the intervention strategies designed to help the patient meet their goal. And this can include providing information, teaching a new skill, problem solving, increasing social support. And then in the arrange phase, the BHC informs the patient follow-up is necessary, if so, with whom and when. This can be with the BHC, with the PCP, with a referral, and during follow-ups, the BHC would provide further support and assistance, or the treatment plan might also be modified. These are some of the common behavioral interventions that a PCP might deliver, and I won't go through each of these in detail, but what's important here to know is that our interventions are informed by the contextual factors, again, provided by the patient and tailored to meet their specific needs and behavioral profiles. So we're not always able to adhere to a specific evidence-based protocol for a particular disorder. Again, it's very contextualized to meet the needs of the patient at that point in time. And next, I'm going to talk about some common clinical considerations that emerge in a primary care setting when working with individuals with SMI. I'm going to ask again for you all to brainstorm some common issues, some common clinical issues that you think might emerge when working with this population. Get to my other question. Okay, so I think if you follow that same link again, it should take you to this second question here.
I put it back in the chat box again, just in case, but I see some coming through here. And then there's a few in the chat. Give me 1 second.
Okay, I see a lot of really great answers, with support being the most common one. Anxiety, substance use, med adherence. Yep, these are all great. Social determinants of health, finances. Yes, these are all things that definitely interact. Yeah, I'll give it another minute to see if anyone else wants to add anything. Yeah, so those are all great answers, and certainly issues that we see come up a lot with our patients. A couple that I decided to focus on for this talk have to do with issues that kind of intersect between a common health issue and medication, sort of the intersection of those two. So the first one that we see commonly is this issue of patients taking psychotropic medications and seeing rapid weight gain. So this is a common clinical challenge. And there are many factors that contribute to weight gain with SMI populations, and this includes just individual susceptibility gain, certain lifestyle factors that I touched on earlier, as well as the use of medications. So many different psychotropic drugs can cause weight gain, including conventional and atypical antipsychotics, mood stabilizers, and tricyclic antidepressants. And there are different mechanisms through which these can contribute to weight gain. Antipsychotics appear to stimulate appetite in some patients, although the underlying mechanisms are not completely clear. Estimates of the prevalence of overweight and obesity for SMI populations are between, it's sort of a wide range, but between 25 to 58%, compared to 33 to 35% for the general US population. So they're quite significantly higher. The largest body of research exists to support associations between weight gain and treatment with olanzapine and clozapine. So with olanzapine, you see an average weight gain of about 5 pounds per month, and with clozapine, about 3.75 pounds a month. There has also been documented changes in weight with treatments with other antipsychotics as well, although the associations are not as strong as with those other two drugs. And so talking about some treatment recommendations, first, patients should be advised upfront about the possibility of weight gain when beginning an antipsychotic and monitored during treatment. Oops. There we go. Sorry about that. This way, it just can ensure that any weight gain that they do see doesn't come as like a shock to them, and can just improve treatment adherence during the course of treatment. Patients can also be referred to a BHC to be provided with information about lifestyle changes to prevent and manage weight gain. Cognitive behavioral interventions that provide diet and exercise modifications have been demonstrated to be effective. And so strategies such as reducing caloric intake, increasing physical activity, reinforcing positive changes in habits are the three major behavioral management strategies that are the cornerstones of behavioral treatment for this population. Patients with schizophrenia have demonstrated interest in losing weight and willingness to participate in weight loss programs. Several review studies have demonstrated that patients with SMI can safely lose weight with behavioral weight loss strategies. So one case example that I wanted to touch on was the case of H, who we're seeing here at the Center for Healthcare Services. She's a 40-year-old female diagnosed with schizoaffective disorder, started on Latuda back in March of last year, and she was referred by her PCP to our service for weight management and anxiety. She had reported that since starting on her medication, she had seen a rapid increase in weight. She had experienced significant anxiety about this weight gain and was considering stopping her medication due to this side effect. And the thing about the specific medication that she was on is that it has to be taken with a significant amount of calories, 350 calories while you take the medication. So we had implemented some diet and exercise modifications, and had talked with her about the costs and benefits of continuing versus stopping the medication. We had worked with her on some cognitive restructuring to help manage the anxiety surrounding the weight gain. But what can be more challenging working with patients like her is that first you kind of have to problem solve the real barrier there with taking the medication with such a high calorie food, and really helping her determine what is the best point in the day to take this medication to where you're not adding a significant number of calories to your day. So helping her figure out to take it with a meal. And she also had real factors working against her. So thinking about gender, age, and she really had to reduce her overall calories that she was consuming, and she was engaging in a significant amount of exercise. So I think for her, she had started running 5Ks regularly, going on 60-minute daily walks, and still in the beginning, just maintaining the current weight she was at, and then slowly started to see some weight loss. But it really took a lot of work to manage some of that anxiety and expectations around what her weight loss path was going to look like and what she could expect. Another clinical issue that we've encountered is hyperprolactinemia and pituitary adenomas. And so antipsychotic medications have been associated with high prolactin levels, as well as linked to the development of pituitary adenomas. So prolactin is a hormone that is secreted by the anterior pituitary gland. It plays an important role in breast development and lactation in women. And it also has other biological functions as well. And hyperprolactinemia is defined as a sustained increase in prolactin levels above the normal range. And it can be due to various causes. And what is alarming about this, however, is that it associated with a host of negative outcomes, such as sexual dysfunction, altered production of sex hormones, and an increased risk of osteoporosis. Antipsychotic-induced hyperprolactinemia can occur in up to 70% of patients with schizophrenia. So when it comes to managing this condition, there's no real consensus out there on how often prolactin levels should be monitored. However, some sources advise monitoring prolactin at baseline when starting any antipsychotic medication, again at 3 months, unless symptoms start to present, at which case prolactin levels should be monitored more often and sooner. Imaging tests are advised to monitor for the presence of adenomas. Patients should consider alternative antipsychotic medications. This should be considered the initial management choice for patients with antipsychotic-induced hyperprolactin levels. Adverse effects are generally dose dependent, but certain antipsychotic medications can have profound effects on prolactin levels at relatively low doses. However, the management strategy selected will depend on the distress caused by the symptoms, the benefits from the antipsychotic drug, as well as the risk of relapse should the dose of the medication be reduced or stopped. So there are a lot of factors that need to be considered. Also, another option is the addition of a dopaminergic drug, such as bromocriptine. These drugs have been used to treat this condition and have not shown any worsening of psychosis. And so they are another great treatment option. And another case where we have seen this come up is with the case of N, who is a 23-year-old female that we've seen here in primary care with a diagnosis of schizophrenia, who is on Invega Sustenna injections with high prolactin levels, as well as a pituitary adenoma that was resected back in 2017. She has a history of feeling quite unstable on different antipsychotic medications that she's taken in the past. And this is the first time that a medication has really helped manage some of the symptoms that she's experienced. However, it's been really important that she's continued to be monitored for her prolactin levels and continue to receive imaging to detect the presence of adenomas. She's recently been started on bromocriptine to help manage those prolactin levels. They've continued to remain high due to insurance barriers that she's faced. She's not able to continue to receive imaging testing this year, and so it continues to remain even more important that the prolactin continues to be monitored. And so our work with her on the BHC team is to check in about medication adherence, making sure that she continues to receive her injection, she continues to take the bromocriptine. And we've also been working with her on weight management, which again is another side effect of the antipsychotic medication. And she's done very well and is in a very good place and has great follow through with the diet and exercise interventions that she's working on. And just to summarize some of the main points of the presentation. So again, the overall aim of the primary care behavioral health model is to help the primary care team manage psychosocially influenced health problems with the goal of improving services for the overall clinic population. emerging research demonstrates that the models associated with positive outcomes for the general and the SMI population. And there are various patient, provider, system level factors that may interact to affect health outcomes for patients with SMI, creating many unique clinical considerations for us to consider when working with these populations. That's everything. Thank you so much. I'm happy to take any questions.
Just gonna say, if we have any questions, I don't see any questions in the chat box, but you can unmute or put them in there and I can read them off for us.
Hi, this is Rose Ramos. I have a question about engagement with like a family-centered approach to improving adherence to the medication, especially in light of weight gain. I found that just anecdotally that family members can sometimes be the biggest adherent or barrier to adherence, because they do not understand the weight gain implications of the medication. Or sometimes there is this feeling of guilt of the individuals that they haven't been a good partner, a good family member. And so they try to please, and when comments are made, oh my gosh, you're gaining weight, or don't eat so much, that's why you're putting on weight, it just further impedes successful treatment with the patient. What are your thoughts on family engagement in the approach to strategies that aim to improve adherence to treatment?
Yeah, that's a great question. I have to say, here at the center, we don't do a lot of family-based work, although individuals will sometimes come in with a spouse or a partner. I will say what might be helpful if you feel like maybe the patient is receiving that sort of message, or that sort of barrier is coming up, maybe doing some values-based work with the patient could be helpful. So figuring out why that goal might be important or might matter to the patient, or what is it that does matter to the patient? What is it that they value, and what is it that's important to them and that they want to improve? So maybe starting there and trying to get that sort of clarity from them, and really hearing it from them could help foster some of that motivation. Sometimes I think when you're getting some of that interference, it can be hard to really get a sense from the patient of what it is that matters to them and what they're working toward. I've also found that just doing a cost benefit analysis can really help, because oftentimes there really are, pros and cons to these issues that are really complex. So sometimes if you can just sit down and kind of sort it out with them and really weigh, what are all of the reasons that I want to keep taking my medication, and what are some of the reasons that I want to stop taking this medication. And if you can get them to maybe get all of that out and get all of those factors kind of sorted out, they'll kind of come to see that maybe some of those pros can overcome some of those cons. And I think exercises like that can be helpful as well. I'm also not sure if you're ever, in the setting that you work in, able to kind of speak with individuals independently, or get members of the family kind of one-on-one, but I know from some of the past work that I've done that that's always been an approach that I've tried to do as well when I feel like I'm getting too much input in the room all at once.
Thank you.
I'm not sure if you can see the chat here, but Dr. O has asked specific strategies you would suggest to improve PCP confidence working with patients with SMI in primary care.
Yeah, so I think that's where the education piece can really be really valuable here. So I think a lot of PCPs maybe discomfort working with this population just comes from inexperience or lack of understanding of maybe some of the reasons that these patients might present the way that they do. So I think a lot of just education around that can be really important. One idea that we, Dr. Aguilar, my supervisor, and I were talking about recently as an approach that we were considering is the discussion around ACEs and how so many of our patients here at our site have so many traumatic experiences that further influence their presentation and both their mental and physical health, and how really taking a trauma-centered approach with them could be really impactful and really help the way that providers respond to our patients. And so I think any way that a BHC can find a way to provide some of that education. I know for us here at our site, a way that we try to do that is through our monthly interdisciplinary team meetings. We have time during those meetings to present a research article, and this month we're considering a presentation on ACEs. And so I think that's one strategy a BHC might try to use.
I don't see any other questions in the chat, so I will go ahead. We can thank everybody for joining us. If you could, please remember to, I did put the evaluation link in there. And thank you so much, Samantha, for presenting to us today.
Thank you so much.
Have a great day.